Welcome to this presentation. Unfortunately, we couldn't join you in person because we have our own annual conference for DHIS2 here in Oslo. But we would like to present how we are working on climate and health to predict disease incidents. I'm Bjørn Sandvik. I have worked on this project for 8 years. I'm a GIS expert, and I worked as a GIS lead on this climate and health project.
Yes, I'm Int'l Sandve. I'm a professor in machine learning here at the University of Oslo and leading the development of a chat platform that I'll present.
And I'm Patrick Omiel from DHIS2 Uganda. I support DHIS2 implementation both in Uganda but also within the East and South African region. And that's really what I'm doing for this project. So so maybe to get started, it's very important that we help the team understand what DHIS2 is. So what is DHIS2? So DHIS2, based on the implementation, is one of the world's largest health management information systems that is used in over 80 countries and mainly in the low and middle income countries. And this software platform is developed by DHIS2, but the implementation is supported by the HISP network that mainly is constituted of over 23 HISP groups. And these groups are based in countries, and I happen to be one of that part of that group. But basically, this is a group that directly works with the ministries of health and the local implementers to make sure DHIS2 is operational in country. Yeah, so this software platform is open source, and that means that it's free, but the data ownership rests really with each of the institutions that does the implementation of DHIS2. By design, the software platforms allows for integration, and in a way, most of the countries have done a lot of integration already of data, including this climate data. We are leveraging on this capability to be able to get in the climate data within the DHIS2 platform. So why are we implementing this? Why is DHIS2 being implemented for climate and health? So this really stems from the fact that climate change is defined or known to be a single biggest health threat facing humanity. That's really what WHO indicates. And so this work comes in really to see how we can strengthen climate resiliency of health systems. And this we are going to do, we think we can achieve through, of course, integrating and harmonizing climate data within this DHIS2 platform and building analytics, both, of course, using the core DHIS2 analytics, but also models, modeling tools within the DHIS2 to be able to look at the relationships between climate factors and health outcomes, but ultimately to provide actionable information to decision makers and health workers. So this project is an 8-year project, but with funding in the first 2 years. But within these first 2 years, we need to demonstrate results that should be able to help us go into the next 6 years of implementation. So key to this, I already mentioned that we intend to do modeling and prediction. That should be really what should support the early warning system that we think will make the best use of this climate data within the health or with health. And so why is this really useful and important? This we think can be a way to, of course, predict health epidemics, and with that we should be able to mitigate the risks and manage. And that would mean that then you're able to be more targeted when in terms of your prevention strategies, but also prepare health systems to be able to support this, but also tailor campaigns on similar caution so that your campaign messages is more tailored. But also in terms of planning, strategic planning, we think this can actually help prepare countries to be able to plan for new diseases that are predicted, but also design prevention measures that can help to avert or mitigate the risks of the climate change. So over to Björn.
So we saw when we started that to be able to combine health and climate data, there is some data harmonization that needs to be done. There is also the challenge where there is a lack of data and also lack of continuous data in the countries. So we needed to look into different way of getting this data together. We saw that the data used locally in the countries, that is the best data most of the time to use, but there is a lack of good software data repositories, and also often the data is connected to individual weather stations, which might be hard to combine to the health districts where we have the data. But luckily, a lot of the data in the countries, these automatic weather stations that is all over the world, they are shared with the WMO, the World Meteorological Organization. And then these are made available for the wider global community. And currently is this European Center for Medium Forecast, this ECMWF, that is currently best in class of combining this data. Also, where there are gaps in the data, they would use satellite models, and also they will run the same climate models that they used on the future. They can also run on the past with much better results, because we always have the weather station data where we can calibrate a model so we get the best possible results. I've shared a link to a video on this slide where you can see a good introduction to this reanalysis. And then luckily for us and also for the wider world community, this is open data that is being shared on Google Earth Engine. They also produce a 10 days weather forecast, which is not available in the public. But if you have a connection to the Met Office, Meteorological Office, they have access to this data. And the Norwegian Met Office, they have actually made an API around this where you can send in a coordinate and then get the weather forecast for this coordinate. And this is used on global data, so it works all over the world. And these two data sets we have included in an app in our system, which is called the DHIS2 Climate App, which then it can be used to harmonize this data with the health data in DHIS2. Could also just mention that both this API, Meteor API from the Norwegian Met Office and DHIS2 are both considered as a digital public goods, so free available sources available. So to harmonize the climate and health data, we use a common GIS technique, which is called zonal statistics. I'm sure many of you have worked on it. So what we do is that we take the boundaries of the health district, and then we take this the data we have within that and calculate the mean and max or the precipitation. So we calculate the average for each district. If for a health facility, we just select the value within that cell. So you can see this is just an example for Sierra Leone. The resolution of this data set is 9 by 9 kilometers. So it's pretty high resolution, and often this is better resolution than the density of the weather stations in the country. Just also to mention that the same technique we are doing here, we can also do on local climate data. So we have done some testing with Malawi, where we are using local climate data and do the same techniques to harmonize the data. So this climate app is something you install to our health system. It's just basically very point and click. And when you have the app installed, you have access to the same health district, the whole hierarchy of a health district as you do for the health data. And then on the fly, we are then able to calculate the data for this district. So this is some of the outputs. Often with this data, it's not the temperature in itself is maybe not so interesting, but especially when it's changing from the normal. So whenever we show the data, we are also calculating the climate normal. So what's the average for a 30-year period? And then we calculate the data for the last year, for example, and you can see if the temperature has been above or below the average. So you can see in most of part of the world, it was record. We had this record heat last year, and you can see this dotted line is it's the average, 30-year average, and this is the actual temperatures for this specific district. Same we do with the precipitation. We are also looking a bit further to look into heat, because temperature in itself is not necessarily known to measure the heat stress. It is also influenced by the humidity, pressure, wind, radiation. So this is an indicator where they are combining several variables into one to measure the heat stress, which is also comparable between countries. So this is just an example from the heat wave in Delhi last week, where you can see for the day temperatures on the top here, it got into the extreme heat stress with first time they had temperatures be above 50 degrees Celsius. So hopefully by just including this data, it might be in the health system, at least we could build some awareness of how the climate is in the different districts and how it is changing. And then later on, we will see how to combine this with the health data.
Yes, thank you. So, so what we are now looking at is really getting countries to start using this application, and more so now that we've been able to integrate data. So for start, we are looking at about 10 countries, but we also know that many countries have gone ahead to implement this even without notice. And but for the 10 countries that we have HIS groups that directly support them, we know that the 3 of them have been able to set this up in their national instance. But what is coming out is really the areas where there is interest. And we are seeing malaria, we are seeing dengue, we are seeing diarrheal diseases, respiratory infection, and then also malnutrition to be one of the top 5 areas of interest that's coming out from the countries. But this is something that we are going to closely monitor, but also learn from what is coming out of the countries to be able to support them when it comes to implementation. Yeah, so in terms of deployment or how country would want to see this going down to the countries. Yeah, so now that we can have the application import data, so we are really encouraging countries to set this up into their national DHIS2 instance and be able to explore. And here is a case of Rwanda. They were able to set this up into their production instance, and they've been able to start building some of these analytics like the one you're seeing on top here. But also for other countries like Uganda, they're looking at setting this up within their malaria repository, which is not the main HMIS instance for DHIS2. So there could be these program-specific implementations that could also happen. But the most important thing is to make sure that you can work with the country DHIS2 administrative structures to be able to start exploring this data. Analytics is still in development, but the first step, of course, with that we've been able to achieve, of course, is to integrate data and start harmonizing data. But even with that, we encourage countries to start exploring, developing analytics. But we also think we could develop some global resources and share down to the countries. But at this point, we're really encouraging that, they work with programs who are really the people who have already been doing some work around climate and health. And this is an example of what we're able to get from the field, where they're looking at malaria suitability And here they're looking at, temperature, precipitation, and relative humidity within certain ranges, and then being able to define what is suitable for malaria transmission in a given period of time. And here you could do a map, but also you could do a table where you can put districts for the different months. And this is also a good example of triangulation that's coming from Mozambique. And so we think that there's a lot of learning and building on existing knowledge. And when we get this, we could also put within the resources that we can share with other countries.
So triangulation is great in many cases, but it's also a bit challenging because this climate and health data is quite complex, and the relations for how climate is influencing mosquitoes, for instance, in terms of malaria, the parasite, the human behavior is very complex, and it can be hard to do by pure eyeballing. And for that reason, a mathematical model can be advantageous, especially if you want to have uncertainty. So the ranges that are likely to happen. The second thing is that, like, if it's really subjective, it's hard to build evidence on how useful it is, because it depends on the human that does the evaluation. If you have a quantitative formula, you can kind of quite rigorously assess how well that formula is working. The third thing is that we also want to know which questions we can successfully answer. For that reason, we want to have a quantitative model for many different potential use cases and be able to critically assess that and see where we should focus our efforts on implementation and operationalization. We will do this what is known as a DHIS2 style, and comes back to the DHIS2 system, where we say that we cannot just take one system and apply it to every country. That doesn't work at all. It needs to be really matching to the local context. It needs to be owned by the local context. It needs to be developed in the local context, and thus be different. But still, we don't want to develop everything from scratch at every place. So we want to reuse software, we want to reuse experience, and we want to have a sharing of experiences across our community, so that when an innovation is made, like for instance in Mozambique, we want to have a process in place so that other countries can also get inspiration and use these developments. Finally, how to integrate this with like statistical data and related to socioeconomic factors, population, mobility. That is a very interesting factor, because in most of these countries, Google Earth data, for instance, that Björn introduced, is available. It's a decent resolution. It's well harmonized. It has been quality controlled. So that is a bit standard. The health data is also a bit standard in terms of WHO guidelines for how to report and how to record it. And it's also in the same format in this DHIS2 system. But when we want to predict disease incidence ahead, some of the most important factors are related to socioeconomics and population, mobility of people between regions, and that is crucial for the modeling. It's very individual to every country, and it's typically not as harmonized and as broadly available. So we really want to have that. We want to have like open data sharing policies within countries related to this, in order to be able to scale it up to work in like 70+ countries, which is the scale for DHIS2. It's important that these are in standardized formats so that it can be a bit more easily reused across countries. Also, ideally, we would want to have API access, because you can always download and upload data and so on, but it's a manual process. It can be a bit tedious and it's hard to automate. So having that available through API would be great. And finally, at a more technical level, it's important that this data can be aggregated to the health districts where we have health outcome data and where we now also have climate data. And that have to do with like how the data is recorded, the resolution, and that it's possible to aggregate it within a polygon that we say is a region of a country.
Yeah, so we had a couple of questions ahead of this, and so one of them was really what would be the biggest challenges in delivering this. And then, of course, the concerns around data, or whether it's technology, or finding the right talent. But I think from our perception, the biggest, which has just already been mentioned, would definitely start with data. We have some good health data, having worked with the health programs for many years. But there are other dimensions here, more so when we get into modeling, where we will need to have data coming from other sources, social, economic data. So that will definitely require that we go a little more in looking for these other sources to be able to make meaningful modeling and prediction. But also on the other parties, implementation, taking this down to, you know, district level, where at that point, you know, there are a lot of challenges with, you know, capacity of people to actually run this by themselves, but also low resource setting in a way that even when you make predictions and you provide information that should actually trigger action, the resource limitations within some of these settings would actually not really allow some of these actions. And so to take place, and in that way, you definitely have low use of some of these at some levels. But nevertheless, we really intend to make this to work even with these challenges. The other question, which is on the on public health communities, and this is really speaking to the current community that we have around DHIS2, because there have been, started from within the health space, and so the community that is within DHIS2 are mainly public health practitioners, and within that. But now, of late, DHIS2 is expanding this space. We are now doing work in education, in agriculture, and cross-sector. And so the expansion of DHIS2 communities really is driven by implementations. So we think this space would definitely need to change with the new implementations that's coming in some of these spaces. And more so now, if you're looking at climate that will require more. So this should definitely change over time. And with the involvement of the statistical office, in a way, this has already been happening. We've been working with statistical offices to provide, you know, population data that we've used for most of the denominator that's used with the health program. So we think this relationship can be further improved in country to make sure that we can get more, especially around the socio-economic data that may be of interest for this work. Okay.
Yeah, and for the second question, I think it's really interesting about this continuum between indicators and more direct predictions of the outcome. And I think my thinking is that especially initially, the more part of the process a human can take, the easier it is to ensure that at least the predictions are not deteriorating the current practice. So I think, like, if you can have indicator for some certain parts of climate suitability that is easy to quantify, and then allowing humans to do the more subject matter, use all the subject matter expertise, do a holistic judgment, that is really desirable in terms of like having this realistic and relevant. But at the same time, it depends on a lot of human expertise, and it's a bit hard to, since it's subjective, it's a bit hard to assess and critically assess how well it works. It's a bit hard to know where to prioritize efforts. So there, I think, together with countries, maybe starting with indicators and gradually building up how much can be automized and made in an objective way, so that it's, and where modeling is developed together with countries, I think that could be a very good approach, where we could then allow good assessment, where we could save some effort, and we could also be less dependent on really local expertise, while at the same time being relevant and realistic.
And finally, if you would like to have some more information on the project, we have provided a link which both describes the app and the tools we have been presenting, but also the overall projects and some use cases in the countries. And if you have any more questions, feel free to reach out to us. You can use this email, climate@dhis2.org. And then we want to thank you for listening and having us to present, and good luck with the rest of your conference. Thank you.
Thank you.